Hi, my name's Beth White. I'm one of the consultants in infectious diseases at the Queen Elizabeth University Hospital in Glasgow. And myself, along with Denise Wilkinson, who's one of our lead nurses on the site, have created this Covid-19 update for the nursing staff. And I've incorporated some questions that Denise has asked me during the course of this presentation, as because of social distancing she can't be with me in the studio just now. So in the course of this presentation, we're going to quickly go into the background to the illness, what the illness looks like, and some of the risk factors for severe disease. Then we're going to spend a bit of time on the modes of transmission, which is really important because that helps us understand then what we do in terms of our infection control precautions and the importance of these. And finally, we're going to talk about the management of COVID, because this has changed since the first wave when we first were managing COVID-19. So a bit of background that a lot of you will already know. This is a virus that has caused over 46 million cases worldwide now and over 1.2 million deaths. This little graph shows you the cases in Scotland over the course of this year, and you can see that there's a small bump in April and May of cases, and then a much larger bump at the end of the year that we're in just now. The difference is probably because we had less testing then, so we don't know exactly how these two waves compare. But you can see that there's sort of different lines here, and the most deprived patients, there's a much higher rate of disease. That's really important here in Glasgow, where we have a lot of deprivation, and that's why we have been hit so hard. So what is the illness like? Well, the incubation is around about 4 or 5 days in the main. It can be up to 14 days, and that's why if you've been a contact, you do have to isolate for that 14-day period. And the symptoms, the ones that you'll be aware of are probably in this red box with the severe illness, because that's what patients come into hospital with. So that's fever, breathlessness, and a cough, but also incredible fatigue and achiness, and for older patients in particular, confusion. So over 40% of old people will present primarily with confusion or just being off their legs. GI upset's also common, with sort of diarrhoea, vomiting being quite typical symptoms as well. However, for people who have mild to moderate disease, the symptoms are slightly different, as you can see on the left-hand side of the slide. So in you or I, we're more likely to get this mild moderate disease, and actually the commonest symptom is headache, and then maybe loss of taste or smell, a bit of a cough, and that kind of weakness, fatigue, myalgia, a bit flu-like maybe, but also a runny nose and a sore throat. And these symptoms are actually more common than fever. So it's important to remember that, particularly in terms of infection control, if you have very slight symptoms, but you don't meet the criteria for testing. It's also important to remember that quite a high proportion of people will have asymptomatic disease. That means no symptoms for the duration of the illness. We don't actually know what percentage that is. In younger people, it's been up to 80% in some studies, but in some studies it's been nearer 10%. So the averaging out is maybe around 40% of people will have no symptoms, and this is really important to know, that you and I can transmit it to each other without any symptoms. We have to be aware of that when we're interacting with patients and other staff. Just to remember, this elderly will have less typical symptoms. So somebody who's off their legs when they're older, that might be a sign that they have COVID. It's much harder to tell. They won't have those typical symptoms of fever, etc., as commonly as other folk. So what is the clinical course of the illness? Well, the vast majority of people will feel unwell for about a week and then they settle down. For patients who are going to get unwell, they typically start to get unwell about a week into the illness, maybe a week to 10 days. And it seems to be switching from this kind of predominantly viral phase where the virus is causing most of the symptoms to kind of an immune phase where it's actually your immune system that's starting to affect you and make you feel unwell. And that presentation, if people are going to get unwell, is typically with worsening fever and that breathlessness, so a progressive breathlessness and an oxygen requirement. Of those patients, only a proportion of them will require to go to critical care. But that deterioration from becoming breathless and hypoxic to getting very unwell and requiring critical care can occur rapidly. So if you have a patient on the ward whose oxygen requirement is rapidly increasing, keep a close eye on them and be very quick to speak to one of the doctors if you have any concerns. So what are the risk factors for severe disease? the main risk factor is age. And so as patients get over the age of 60, their risk of severe disease and of death goes up quite significantly. And this risk factor is head and shoulders above any of the other things such as male sex or ethnicity or other medical problems such as heart disease, diabetes, obesity. So age is the highest risk for death. And you can see this paper from the first wave in the Italian first wave, which was really sort of significant. They had a huge number of cases. Over 80% of deaths were in people over the age of 70. That doesn't mean that every old person is going to die. So actually, when an older person comes into hospital, it's maybe 15 to 20% risk of death once they're admitted with COVID, unwell with it. So the vast majority of them still will get home, but their risk of death is much higher than somebody who's younger that comes in. So how is this infection transmitted? So the key mode of transmission is through large respiratory droplets. And these can be spread to others either directly or indirectly. So these are droplets that are going to come out as I cough or speak, particularly if you're speaking or loudly, coughing, speaking, sneezing, and they'll spread to within 1 metre to 2 metres of that person. So this is spread directly through face-to-face contact, so speaking to someone close up, or if you're in an enclosed space with them for maybe over 15 minutes. And this is why it's so important that we are wearing face masks all the time when we're at work, not just when we're doing patient contact. But you have to be doing it when you're sitting beside others, doing your administrative work or whatever. And it's also why it is really important to socially distance. So if you are going down to have a break with someone, please make sure that you're keeping 2 metres away from that person when you have your face mask off if you're needing to eat and drink. The other really important way of transmitting this virus is through indirect transmission. So this will happen through droplets on surfaces. So as I speak, these little droplets are coming out and they could sit onto my computer or onto a DECT phone if I'm holding it. And that can persist on that surface for up to 72 hours. So it's really important that if you're touching surfaces, a handle, a phone, or using a computer to type something, that you use a wipe, like an alcohol wipe, to disinfect that. And if you're touching any of these surfaces, that before you touch anything else, you wash your hands with soap or you use alcohol gel to clean your hands. And the soap and the alcohol gel help to destroy that outer surface of the virus. So it is quite easily destroyed by these commonly used disinfectants, so please be really mindful about using them. The alcohol works as it evaporates, the outer particle of the virus starts to disintegrate. So you do have to wait until it's dry for it to have fully taken effect. And this slide is really just trying to help understand the infectivity of the virus. The main part of this graph that I want you to look at is the little blue line that goes up beside the viral genome. And this is the amount of virus in somebody's system. And day 0, you can see down at the bottom here, is sort of almost partway through this graph. So the amount of virus in people's body will start to go up even before they have symptoms. And their actual peak infectivity is just before they have symptoms, 1 to 2 days before, and up to about 5 days afterwards. And so that shows again the real importance of being careful. I might not have symptoms now, but I might be infectious and start to get symptoms tomorrow or the next day. So you have to be mindful of the fact that asymptomatic people can very easily be transmitting this virus, and that's why it's so tricky to stop the spread. Okay, so what does this mean for us? I think it's really important to remember that you or your colleague may be infectious even without any symptoms, or with very mild symptoms that don't meet the criteria for testing. So we need to always wear a mask when we're in a clinical area or when we're meeting people, unless you are sitting 2 metres away from them in an area that's well aerated, such as the atrium in the Queen Elizabeth Hospital. You need to stay 2 metres apart. It's really important to be washing our hands often. And if you're not washing your hands and you've gone and touched the door handle to just pop your head in to see a patient, you then need to alcohol gel your hands. You need to be really mindful of using alcohol whenever you've touched any surface, because you don't know what's been there before you. And this is another reason that we shouldn't be having any food or water bottles in our clinical areas, because you don't know what's around that clinical area is higher risk for having COVID in it. So we should make sure that we don't have food and drink in our clinical areas and that we wash our hands properly before we go for a break. And I think you might well have seen this graph before. This is telling us what we should be wearing in clinical areas. So when you're in the clinical area, at all times we're wearing a mask. If you're going in to look after a patient with either suspected or confirmed COVID, you need to be wearing eye protection, so either goggles or a visor, an apron and a pair of gloves. And the visor and the mask can stay on through seeing several patients, but you should be taking off that apron and the gloves after every single patient contact and then washing your hands. And I wash my hands in the room and then I come out and alcohol gel my hands afterwards because I've touched the door handle. So just being really careful about these infection control sort of procedures. If you haven't got your own visor, you need to be really careful that you have cleaned it yourself before you're using it. So if it's something that is been used by another member of staff, don't presume it's been cleaned before you put it on, but make sure you've cleaned it properly. And this is just some of the simple things. When you're putting on your mask, make sure you've kind of moulded it around your nose. And when you're taking it off, always take it off from the back so you're not touching the front of the mask, which could be the contaminated part. Remember to wash your hands after you've ever touched anything around your mask. Don't pull it down between sort of patient contact. So touching the front of the mask is where it could be contaminated. So be really careful about that. If you're looking after COVID patients or suspected COVID patients, I would put on a clean mask before you go out of that clinical area to go and have a break or whatever, just to reduce the risk of viral transmission. And so this is some absolute no-nos. Please don't pull your mask down below your nose or down below your chin. It's not doing you any good. You're actually at higher risk of transmitting it because you might be touching the bit that's infectious. So this is something that we get asked about quite a lot, and it's really quite tricky. How do you step down infection control precautions? And how do you help somebody get discharged? So the key thing to remember is for somebody who's admitted, you have a minimum of 14 days where you have to have these infection control precautions in place. So from the start of their symptoms, so the day 0 of their symptoms, or if they've not had symptoms from the day of that first test, and they have to be fever-free for 48 hours to show that they're clearing it. So you've got 14 days from the start of that illness, and they have to be sort of kept away from others during that time. So if that person go home before these 14 days, you could send them home possibly with a household contact if they've already been exposed to that person. But if that's not possible, they shouldn't be getting a taxi or any other kind of public transport home. You ask the Scottish Ambulance Service if there's no other options, and you can speak to them via the demand and capacity manager. When you're sending someone home, you might want to think about things like household members who may be very high risk for various reasons. And if you've got questions about that, please speak to the infection control team. Discharge to a care facility is slightly more tricky. You've got those same sort of criteria of minimum of 14 days of since the symptoms have started and an absence of fever for 48 hours. But we also do need to have 2 negative tests at least 24 hours apart. Now, there are some caveats to that if there are exceptional circumstances. And so if you've got questions to that, then please do again speak to infection control or one of your senior charge nurses. So what are the treatments that we can give for COVID-19 pneumonia? Well, oxygen remains the mainstay of treatment for people who become really unwell. You're aiming for target oxygen saturations of 90 to 94% in the vast majority of people, but 88 to 92% for patients with COPD or at risk of CO2 retention. Something that we found is really valuable is considering proning for patients, and that's what this gentleman in the middle of the picture is doing, so lying onto your tummy. And this helps to open up the airways. You've actually got a lot more lung capacity at the back of your lungs. So if you're sitting on your tummy, you're opening up that larger part of your lungs and helping to oxygenate it. And we should be using this on the wards and not just in critical care. So if you've got a patient who's requiring oxygen on the ward, then do encourage them to go prone, to be on their tummy for as much as they can tolerate, because it really does help with their oxygenation. This is just also a reminder that we shouldn't be using NIV or CPAP, home CPAP machines or whatever on the wards, that these can be aerosol generating procedures. If you've got questions about that, then please speak to infection control or one of the doctors on the ward, but we shouldn't be using these things on the ward out with very specific circumstances. The other thing that we've become very aware of is that there's a high pulmonary embolism risk with these patients. So in critical care, they found that up to 1/3 of patients with severe COVID pneumonia have a PE as well. And this seems to be sort of disparate to other infections or other kind of clinical conditions that we see. So we need to remember the risk of PE, and if your patient suddenly deteriorates, more breathless or blood pressure drops, we need to consider PE as a cause for that, have a low threshold for investigating these patients. And this also means it's really important that all our patients are on some sort of anticoagulation, either standard treatment, low molecular weight heparin prophylaxis, or if they're already on warfarin or a DOAC, then that's okay. But if they're not, then you should be questioning that. I think it's really valuable to have your support to make sure these patients are all on DVT PE prophylaxis. So dexamethasone is the other treatment that we become aware of, and this is a really valuable treatment for patients with severe Covid-19 pneumonia. So the recovery trial that we were part of in Glasgow found that dexamethasone, 6 milligrams once a day, reduced deaths in critical care by 1/3 and deaths on the ward and patients requiring oxygen by 20%. So this is a treatment that everybody who requires oxygen should be considered for and should be on unless there's a good reason not to have them on it. But it's important to remember that there is not actually benefit for patients with mild to moderate disease, and there actually may be harm, so it's only for patients who do require oxygen. Dexamethasone comes with its risks though, and as a steroid it has an increased risk of increasing blood sugars. And actually Covid-19 independently causes an increased risk for blood sugars going up. So this is important for diabetic patients. It may really worsen their diabetes control, and they may need significantly higher amounts of insulin if they're on insulin. But actually we've found that this can cause high blood sugars even in non-diabetic patients. And so any patient who's on dexamethasone for Covid-19 pneumonia needs to have a blood sugar checked at least once a day. And the diabetologists tell me that's best done at 4 p.m. because that's when you're going to get that highest blood sugar rise after a dose of dexamethasone in the morning. So every patient on Dex should get a blood sugar check at 4 p.m. every day. And in diabetic patients, you want to be doing it 4 times a day. The final treatment I want to speak about is remdesivir, and this is a treatment that there's still a lot of debate on at the moment, and we may be changing our guidance on this in the next few weeks. However, we're still using it. It's an intravenous antiviral treatment. It's not been shown to improve mortality for Covid-19, but there is maybe some benefit in an earlier recovery for patients, and particularly for those presenting with early severe disease. So at the moment we still are using it for that group of patients, but this is something that's being discussed at a national and international level at the moment. And it's a 5-day treatment course, so it shouldn't be any more than 5 days. There's no benefit of benefit out with that, so it's 5 days and stop. So the other area of care that's really important is palliative care, because not all our patients will survive this illness. And so I'm not going to go into the details of this Scottish palliative care guideline, but it's really helpful. And I think if you've got any questions about how to manage a patient who is likely to be dying of Covid-19, then please speak to your palliative care team. We have really good palliative care teams in Glasgow. So please get in touch with them and get their advice as to how best to manage these patients. So I think that's the end of my talk. And if you do have questions, I'm aware that this is online, but I'm very happy to take an email, or if you catch me in the corridor, my email is beth.white@gdc.scot.nhs.uk. Thanks very much.